to everybody. Good afternoon, good morning, good evening. As indicated, I'm Elvis, a permanent lecturer at St. Monica University. And myself and my team will be presenting on this webinar entitled Community Engaged Healthcare Projects and Youth Employability, taking cases from Cameroon and South Africa. In part one of the session, I will be presenting together with Thomas Ryder and Kennedy Abendum. Trang already introduced their profiles. I will be talking a little later in the course of the presentation. In the agenda here, I'll give a brief introduction about our project, and then Thomas will come in to talk about M2Raj, a mobile suitcase that we are currently developing to use in our healthcare services, while Kennedy will present on the project currently going on at Access Care. Access Care Clinic is a product of the Monica franchise project founded with support from the Terrorist Network Support Grants. I'll talk briefly on the Health Center franchise project. It was initiated in 2013 with the aim to ensure that all graduates, or most of the graduates from St. Monica University, are able to set up health centers across Cameroon. In doing so, they'll be able to provide the badly needed healthcare services to communities, especially those which are underserved and to people who are uninsured. And these graduates, in doing so, will be able to get jobs for themselves and increase or improve on their economic life. The main goal here is to address three issues: provide the most needed healthcare services to the communities, especially those who are underserved, provide jobs to the graduates, and also strengthen the local economy. It begins from class. We prepare the students right from class ahead of these tasks. There are three basic and integral components that we integrate into it. First, we have tried to introduce some courses aimed at making the students able to carry out these tasks in the field. This basically or notably includes informatics and telemedicine. We have visiting lecturers who come and teach the health students in particular on health informatics and telemedicine. These are the novel tools that are being used nowadays to carry or ensure the delivery of healthcare services, especially in homes to those who are underserved and don't have the easy access to health facilities. We also try to network with other partners to ensure that this goal is achieved. We cannot provide the necessary equipment that the students need on the field. Networking with the Brandenburg University, with in particular Professor Thomas Ryder, ensures that we are able to deliver an equipment that the students can use while on home care services. The students are also trained to be entrepreneurs. Remember, I said the students are to establish healthcare facilities across the country. So each student, according to our project, is to own at least a healthcare service, which will now be serving the neighboring or the immediate environment of the clinic. A single clinic cannot suffice to address the acute problem that we have, as I'll be presenting shortly. So these students also need to be able to collaborate with community organizations. Mr. Kennedy Abendum will be presenting a little bit on how Access Care is actually liaising with community-based organizations, the CBO, to ensure this. So the students are prepared in class through health informatics training and telemedicine technologies. The students are networked to collaborate with the different communities and the partners to ensure this goal. And finally, the students are trained using the St. Monica Health Center as an incubator for now to be able to run a health center on their own. We have facts to justify what we are doing. Cameroon is currently included or listed in the list of countries with critical deficit of health force across the world. And in particular with Africa, you can see Cameroon there. And this is not the only problem Cameroon has. Cameroon also has a huge burden of non-communicable diseases and, to a greater extent, communicable diseases, which are the biggest problem that we have. So to be able to address this, we have been able to identify the problems. First, we have the diseases available, the diseases causing huge problems in the community, especially communicable diseases like malaria, HIV, respiratory infections, tuberculosis, and the patient to doctor ratio is also very alarming, as you see in the statistics there. Nurse to patient ratio is also very, very bad, and other statistics that can be used to justify this. Similar situations will also be seen in South Africa, as Anita will be presenting shortly, that we share common problems. We have diseases well identified and established, and we are all both trying to seek solutions through community engaged healthcare services. I've tried mentioning the statistics here. You can see HIV, malaria, and lower respiratory tract infection as the biggest problem that cause either premature death or death as a whole in Cameroon and most African countries. So to be able to address this, as I indicated, we have three basic components that we use as integral part of the project. First, we have networking. Second, we have entrepreneurial incubation. And then third, we have the clinics themselves, access care clinics and Monica Health Center. So I will want to invite Professor Thomas Ryder from Brandenburg University to present on I would like to invite Professor Thomas Ryder from Brandenburg University of Applied Sciences to present on MTRASH. MTRASH is a mobile suitcase that we are trying to develop with his help to enable the workers, especially the nurses, to go to the field, do rapid diagnosis of patients in their homes, and then relate with a physician on the field, a physician in the clinic, and get the necessary prescription and administer to the patient. Our main problem is that we cannot be able to establish health centers to every student that we graduate. But with the help of MT, right, these students can be able to go to homes, do their treatment, do the necessary services, and also earn a living from it. So I will call on Thomas now to come on with his presentation.
Okay, thank you very much for the introduction. I tried to share my desk. Okay. So, you see this presentation?
Yes.
Great. Okay, I want to introduce our work to provide medical services, healthcare services in rural area. And my colleagues, Marius Liefert and Dennis Wagner, we worked together on this topic. And this project started 2 years ago with my students from the technical school here in Brandenburg. And we observed a very complicated situation in rural areas in Cameroon. And we have typical problems there. We have the problem that the mortality of the children and the mothers are very, very high. It's a factor by 100. In Germany, we have about 1 person in 100,000 live births. And in Cameroon, we have a death rate of 500, about 600 persons. and it is a really tricky problem there. That was our starting situation to discuss this problem to provide medical services in this area. And besides this problems for the children and the young others, it's a more general problem there. In this area, we do not have any information about the health situation. We do not know how many persons are serious or how many persons have different kind of diseases. And so it's quite complicated to organize healthcare services very effectively. And then we started to think about the requirements, and we said, okay, we want to improve the situation. We should establish a system that is not expensive, it should be low cost. We want to collect different kind of data and biosignals, and it should be quite easy to use and very flexible. So, and from telemedical services, we know that the technology is not the most important part of such projects. We have to embed this technology in a complex setting or in a better setting. We need a general concept for success. So, but the discussion is, what does it mean? What is easy? What is cheap? And what does it mean, an embedded concept? And maybe, you know, this car here is a typical 2CV, and you can think about what is the common ground of both things. Both things were really, really cheap, and they use very, very easy technology. They simplified everything. They reduced the functionality to the most important aspects. It's quite interesting to read the history about the car from 2CV. They said, okay, we want to build up a car. It's like an umbrella for wheels, and they specified very, very basic requirements. And they built up this car. It was quite cheap, and it was successful. More than 8 million cars were built during this time from after the World War II until 1990. So this was the basic idea behind our concept, and so we started to think about the different technologies. The main problem in general in developing country is we have quite difficult medical problems, and we have only limited resources, it's clear. But to understand or to improve the healthcare situation, we need a concept to say how we can improve this. So one point was to say, okay, we need a local mobile system to collect medical data. And this medical data and the basic treatment should be done by a medical trained person, not only by the physicians. Because physicians are only few available in this area, we need medical trained persons, nurses or somebody lower than a nurse. So we think that it's quite useful to establish something like a medical street worker. They can use this our technology and collect data and decide what should be done for the specific data. It should be quite easy. It's low-cost technology, and we have to implement tools for data management, local level and the central level. So, and in the first step, we tried to be very, very focused on different use cases. We started with this pregnancy woman. So the concept which we developed, you can see it here now, is quite easy. we have the possibility that the patient can go to the hospital, or the patient is visited by the medical street worker. In both cases, they collect data, they document the treatment and live vital signals and so on. And these data are stored on the computer and can be sent to a central service in the cloud. And these data will be evaluated and analyzed and can be used for the government or for greater hospitals to improve the healthcare services in such rural areas. Okay, this is the basic step. The next step was to say, okay, how we can implement the mobility aspect. So we bought a very easy suitcase. The version 4 what we use now, but the first version was really a suitcase from the do-it-yourself market, very cheap, and we put everything in this suitcase. Now we have a better version with monitor, with barcodes, with a very small computer inside with Raspberry Pi, and some laboratory equipment. We can program this using standard programming languages and a local database. So it is quite cheap. We can adapt this setting for different use cases, and this is what we want. So the eHealth platform integrated in this suitcase offers the possibility to collect different kind of data, for instance, temperature, blood pressure, blood sugar, breath, and so on. And the system is quite flexible, using different kind of communication technologies such as WLAN and Wi-Fi cable or Bluetooth. And we can add a different kind of power supply. We can add solar cells or unbreakable power supply, accumulators, and so on. So you see here an overview about the different kind of sensors of the eHealth board. It's a prototype. You can use it for the mental setting. In the later version, we want to establish the basic technology for your own. And the next step also, the next great problem in general, beginning from the pregnant woman until other diseases, is how to add data about the patient. How we can put, we collect important data of the patient. And the usual way is to say, okay, we enter this data by hand using the keyboard. And for the case of pregnant women in Germany, we use some maternal cards, and they collect data from about 70 different items. And if you create an interface with so many different kinds of information, nobody wants to use it. So, and now we discussed how we can improve this process to enter data, and how we can simplify it. And we reduce the amount of data, and we simplify this, and we call it the HEAD model. HEAD means historic data, actual data, current data, and we add a tool, what we call triage. I explain the triage later. And the most important thing is, okay, we can collect data very easy if we use barcodes. We can print lists with symptoms and diagnosis, and besides this list items, we can add a barcode, and this barcode can be scanned very, very easy and very fast. It doesn't matter. We have 10 different items about a patient, and you can scan it very easy, point by point. and it takes only 10 seconds. It's really easy, and we observed that this technology can be really used in the reality. I show you some images later. So, and the reduction of the input this is the most important thing. We decided to create an interface with only some very important and unique items, the name, of course, a birthday. You see this screen, this formula is in German, but we decided we can change it in different languages. So we have here the personal data of the patient. You see here only two great areas for the historical data and the current data. And we can switch it in any other languages. You see here a version for the French language. We implemented this also for English, of course, and we can switch this to the other language what we want. So we created, we have standardized very good data without any errors, typing errors. And the next step is to say, okay, we want to analyze this data. We have in the rural area only persons with only medically trained persons, not physicians. And the next step is that the suit case offers a possibility to say this patient is very ill and should be treated in a hospital or not. And this suit case offers support for this decision. And this means we do a such called triage. We prioritize the patient. It's very early patient, very important to treat this patient immediately, or you have time to treat the patient later. You see here this screen. We implemented such a triage system for diseases with non-infectious diseases, cardiovascular diseases, neurological diseases, and so on. And we have these barcode inputs. We get standardized terms. We have a lot of rules connected with laboratory values, and these rules give us a possibility to decide this case is an emergency case, or this case we have time to treat the person. So in this screen you see that different type of data will be added to the patient, and the system evaluates these data, and you get a score, a triage. You see the yellow signal like an lamp. Okay, this case is not so easy. We should act, react, and the user get an additional information about the reasons and what the person should do. Here, in this case, you should consult a doctor immediately or with 1 month. So, you see, we have now different parts. We have the input, we have the triage system to support a medical trained person in the rural area. And the next step was to decide how we can collect this data to the central service. And especially for the rural area, we developed we call it small size data cube. We added different small sized computers, the Raspberry Pis, and these Pi ensure a very low cost system with low power consumption, and there can all data be stored. So we follow different standards to exchange the data from this small size server cube to the cloud. We implemented a multilingual system based on SNOMED, International Classification of Medical Terms. So we can exchange the information very easy to other systems. So the small size server cube consists of 6 Raspberry Pis with to one cluster. It's not easy to add extra cooling because we designed the shape of this cube that there's no temperature problem inside. So at the end, we have concepts for local and central services to manage different kind of data, medical data. Medical street workers can work outside a hospital, can go from patient from house to house and can add data, can treat patients, and in the hospitals, the physicians can review the cases in the evening and see where are the greatest problems. The medical trained person gets some decision support how to resolve different or difficult situations. And in general, we can use this data for resource allocation from the viewpoint of services. So the equipment is not very expensive, and we are very flexible to different use cases, to different languages, and different kind of data. So thank you for your attention, and you see my finish is, you see this use case is used in Southwest India. We trained the nurses there. These are very experienced nurses, but they didn't work with a computer, and after 1 week they very enjoyed to use this computer to add this data, and they work alone outside the central station. Yes, thank you very much. Hello?
Yes, thank you, Thomas.
Thank you.
Okay, thank you, Thomas. Hello, Trang.
Yes, and the next part will be
Can I
presented
continue?
by Kennedy from
Yes.
St. Monica University in Cameroon. Thank you.
Okay. Thank you very much. I will just go straight away with the presentation, which is going to run through from introduction to the community engagement program, the health insurance scheme that we do. The Access Care Clinic has as objective to actually provide care to people underserved, and this care should be really much more affordable. In a bid to attain these objectives, we do carry out community assessment to establish diagnosis. And usually we cannot carry out this community assessment on our own, so we do a lot of collaboration with community-based organizations, the district level, at the level of Ministry of Health. We also collaborate with the Regional Technical Group for the Fight Against Tuberculosis and HIV. And when we do this, we come out with community diagnosis, and then we design specific projects that we tend to implement to solve some of these problems. One of which, or some of which, include the maternal child and adolescent health education program. Because if you look back at the data Elvis presented, it showed that a lot of problems occur with infants and maternal mortality. And a bit to address this, we need to actually provide some education to the community. We also have to advocate for immunization programs and all of that. Then we also have improving access to healthcare and health-related information campaign to the community, where we bring healthcare closest to the people. Those who may not have access to health facilities, we visit them right at their homes. And you can even see from these pictures how we are collecting samples from patients at home, doing pre-HIV test counseling at home, and testing these individuals to be able to improve health outcomes. Also, we carry out community education on TB and HIV control because Cameroon is classified as one of the countries with high burden for HIV and TB. So in a bid to address these two, we need to give out education to the persons. A lot of them do not even understand the treatment for tuberculosis is free. And a lot of the patients who are with HIV remain undiagnosed. So we are trying to resolve this problem by doing some of these things. On the right, you also see a picture of a polio eradication campaign where we are promoting a vaccination campaign and immunization among children 0 to 5 years old. And then talking about the activities of Access Care Clinic, why at the clinic, we have a lot of facts that we cannot close our eyes to. A lot of our female patients who present to the clinic, particularly among the student population, a lot of them turn out to request for pregnancy tests on themselves, which therefore means they are really involved with unprotected sex and they are scared of being pregnant, so they want to know if they are pregnant or not. We also have up to 20% of patients who present to the facility requesting for HIV tests. So we do voluntary counseling and testing for this patient, and we cannot imagine or minimize the fact that we record up to 20% positive patients, far more than the national statistics, which is just at the level of about 7%. So we see that this is really a big problem. And understanding that these patients have the fear of being pregnant, some of them that we test are actually pregnant. And when they are pregnant, there is a high probability that they will go into criminal abortion because of the fact that the pregnancy is unwanted and they don't want to interfere with their career by continuing their education. So in a bid to this, in the future, we seek to provide HIV screening from door to door among this population. We seek to also provide contraception to this population because some of them feel like embarrassed to want to approach health facilities, even though they may be very close to the health facilities, to provide them with contraceptive methods. So those are some of the things we are going to be carrying out in the future, depending on one or two factors. Then, understanding that the student population too of our country are not really insured in terms of healthcare, a lot of them go to school away from home, and without any insurance scheme, some of them may be very wealthy, but at the end of the day, that family is not there immediately to provide them with the necessary amount of money they need to access healthcare. So we also design a health insurance premium that is going to be benefiting any community, but then the motivation for the development of this scheme was the student population to guarantee their health, because when we guarantee their health, we guarantee their school attendance, and then we guarantee a lot of things in terms of productivity. So based on this scheme, we intend to come up with a lot of benefits. For the population, the benefit the reduction of healthcare costs. We also, and as the results, we tend to reduce the healthcare costs. We tend to gain trust from the community when we resolve their problem at the minimum rate, and then it also increases the number of patients who turn out to the clinic to access care. So to conclude, we're going to go back to Elvis to give some statistics in relation to the health access care clinic in terms of its personnel.
Okay, thank you, Kennedy. Just to recapitulate, the project of the franchise was to address three key issues: youth employment, poor health, and to empower youth through creating enterprises. So the first objective is being met. We have tried to create 2 clinics so far: St. Monica Health Center and Access Care Clinic. St. Monica Health Center currently employs 11 nurses and directly, and close to 20 indirectly. Access Care presently employs 15 graduates who work directly in the clinic and 30 who work indirectly. Students are also prepared for this task, as I indicated. So these 2 clinics serve as the incubators. The students come there for internship, and they are trained, they are linked to the community, they collaborate and work with the CBOs to ensure that they get used to the challenges that they will be facing upon graduation. Networking, thanks to networking, we are able to bring in empty-rights. Students are able to also work with communities and achieve their goals. Noticeable impacts that we have observed so far is reduced hospitalization. The main problem we have is malaria and HIV. Malaria, if you are sick with malaria today, if you are, start showing symptoms today, you don't go to the hospital in 2 days, the situation is going to be very, very critical. So with this, we are able to address the situation before it gets out of hand. The people receive medication at their comfort zones, that is in their homes, and they don't longer go to the hospital. Because when you go to the hospital, you are going to be lying and admitted, meaning you are not working. You are also exposed to nosocomial infections. Hospital-acquired infection, especially methicillin-resistant Staphylococcus aureus, which is a #1 cause of death in our region for hospitalized cases. So this is the milestone we have covered so far. With available funding, we'll be able to open up more clinics and employ more youths and also address most of these health problems. Senator from South Africa is presenting a similar case, but mostly addressing non-communicable diseases, which is a greater burden therein, as I've indicated in the chart I presented earlier. Thank you very much, Strong. Thank you for your kind attention. Hello?
Yes, quite interesting.
Thank you very much, David, Thomas, and Kennedy, for your amazing presentations. We learned a lot from your project in Cameroon with the support from Brandenburg University of Applied Science. For the next part, I would like to invite Professor Sunita Srinivas and her graduate student, Theo Dustberry, to continue the presentations about projects in South Africa. Thank you.
Thanks and greetings to all of you. Can you hear us, Trang?
Yes, we can get to.
So in our presentation, what we are focusing on is responding to our context-specific problems and looking at our local problems. How do we have grassroots level and sustainable solutions where it's more of empowerment of people and using the key concepts such as networking within our students. And where we would like to stress with respect to the employability factor is that when it comes to employability of pharmacists, there are no issues because it's just the opposite problem for us in the terms that we have enough and more jobs available, but because of the brain drain, we end up losing our pharmacists. So employability becomes less of an issue for us. So it's all about introducing the concepts of being enterprising and how to network to look at solutions that we need for our problems. So what we will explain here will be based on a presentation that technically should have been done by Mr. Tandi Mprizi, who is our institutional wellness specialist. Because he's out of station, I'm doing this on his behalf. He started his career with respect to HIV/AIDS because that is always seen as South Africa's #1 problem. And he introduced the concept of peer educators into the system where the support staff have been trained in order to work for empowering all the remaining support staff in understanding the myths about HIV and how to prevent HIV. So we have more than 1,500 support staff and 40 of them have been trained in this peer education program. So what we have done is we have basically used the available program and we have enhanced that program for workplace health promotion team. So here we have some photographs where we are constantly interacting with the support staff to get their inputs. And we are doing all this for 4 different projects which are responding to the big burden of non-communicable diseases. And what I would like to focus on here is that when you look at the Sustainable Development Goal 3, which is to do with health, it is surrounded by all the other 16 Sustainable Development Goals. So we are keeping health at the center of this in our approach. And the other aspect that we are focusing on is how do we promote youth employability and enterprising aspects in pharmacists, future pharmacists, by introducing health promotion. Because pharmacists are being trained traditionally only with respect to treatment and with respect to medicines. Whereas this specific program is looking at how do we use the available South African Qualifications Authority Act and all the institutional policies where we train our pharmacists to have critical cross-field outcomes. And among the critical cross-field outcomes, one of the most important ones is how do we participate as responsible citizens. So as a part of that, when we look at what are the burden of diseases in South Africa, we see that we are always reminded about our HIV/AIDS burden, which is close to 18%, which is part of this 48% of communicable diseases. But what people do not, or what people generally tend to overlook, is this more than 43% of deaths, which are coming from non-communicable diseases. So, and the risk factors for these non-communicable diseases, which are all modifiable risk factors, are to do with a diet which is very high in salt, fat, and sugar, increased physical activity, increased use of alcohol, and increased use of tobacco. So that is what we are looking at. How do we make sure that people understand the problems of these 4 key factors, which are resulting in more than 43% of deaths in this country? The other aspect that we need to bear in mind is, though South Africa doesn't face the problem of critical threshold of healthcare professionals not being met, we do have more than 23 healthcare professionals for 10,000 population, and we have just used the differences here. But we do have less number of healthcare professionals available, and the more we come to rural provinces or slightly backward provinces such as the one where we are in the Eastern Cape, then there is a complete shortage of pharmacists. So when we don't have pharmacists even for dispensing medicines, there is no way we can have pharmacists for teaching about promotion of health. So that is where we are focusing in this project. And what we have incorporated in our project is the concept of workplace health promotion. So the idea of workplace health promotion is, if the workplaces can be used as areas that are inculcating a concept of community involvement and inculcating the concept of using prevention of diseases as the major aspect, then it is feasible to reduce the high burden of chronic and non-communicable diseases that we have amongst us. And our project focuses on our support staff, which means we are focusing on the poor and the unserved or the underserved population. And there are also people who are low literate, which means because of their low literacy level, though the information may be available, they can't make sense of that information to see how diseases can be prevented. So from here, Theo will take over to explain, as a part of his project on tobacco use, and how do we introduce the concept of how it affects the health, and therefore what prevention aspects can be brought in. And then I will summarize the project at the end of this. Thank you.
So what are the benefits of workplace health promotion? Not only to the support staff, but also to the institution and us as students conducting the research, because we are all growing in this project. So first of all, to the institution, if you look at this here, if an institution conducts workplace health promotion programs, it provides a positive and caring image towards about the institution towards its employees. And obviously, if you have healthy employees, then you have reduced staff turnover numbers, reduced absenteeism, increased productivity, which are all benefits to the institution. And also, what are the benefits to the employees is that they have reduced stress levels, which is important in the prevention of non-communicable diseases, and they have increased job satisfaction and all those different benefits. And if we look at the project at Rhodes University that we do here, we're using the available resources and the knowledge of the peer educators, using the health promotion to then work towards community empowerment, to improve teamwork, and to determine how to do sustainable projects. And that will be to enhance skills such as communication, to improve knowledge, education, and importantly, how to influence healthy behaviors. So all these qualities are important to encourage interpersonal skills, and also to encourage professional development that is vital for employability, not only for the peer educators and the support staff, but also to us students conducting this and facilitating these projects at the university. So now to look at the networking involved in this program, we start off by placing the 1,500 support staff in the center, and then networking with an interdisciplinary approach with entities such as the Rhodes University Healthcare Center that currently focuses more on students instead of the staff. So we are currently working with them to extend their services towards the support staff, so they can also benefit from the health services at the university. And another advantage of working with the Healthcare Center and is also the student wellness officer is working in collaboration with the Rhodes University Healthcare Center, and that is an advantage. This project can also reach out to the students at the university. And then we work together with the middle managers, the support staff middle managers. We also work together with the Rhodes University Business School. And this is very important because they help us improve and enhance our leadership abilities, us as the students, as well as the Rhodes University support staff, peer educators, so as they can go out and be leaders in healthcare and health promotion, so they can motivate and influence healthy behaviors, and then to combat these preventable public health issues that affect the workplace in such a way. And one of the things that makes the program so exciting and so enjoyable is we also collaborate with the Rhodes University Drama Department, where they help us to break down those communication barriers between us and the support staff and the end users of the program. They teach us how to conduct role plays and to make the information more relatable, and it improves in breaking down those communication barriers. And so those activities and things will all be included in our health material that we disseminate to the peer educators in the end. Also, the School of Languages plays an important part in breaking down those barriers, where they help us translate our health information, leaflets and information, and they also assist with assisting with the cultural concepts and how do we make our work more culturally sensitive and contextually appropriate, so it's more relatable to the support staff, and they're more open to receiving and becoming part of this project and taking ownership of these projects. We're also working together with the Rhodes University union leaders. For example, they provide us important information on how these non-communicable risk factors influence the workplace in terms of health insurance and all those different things. We work together with occupational health and safety personnel at the university. And also an important channel for us to reach the support staff is the support staff managers, working together with them and in organizing schedules and programs and just facilitating the projects at the university. The support staff managers plays an important role there. Also, networking with one of the most important people here is the institutional wellness specialist, Mr. Kandi Mzizi, which will then assist in taking this project forward and helping with the sustainability of this project. And then we got some excellent news today that the Vice Chancellor of Rhodes University is willing to inaugurate this whole program for us beginning of next year. So that is great news to see that we have the support from the university to take this project forward. So basically, us as students play the central link between the support staff and the Rhodes University management to aid in facilitate the success of this program. So as I've said, we utilize the interdisciplinary approach and from various professional backgrounds, each one that plays an important part: nurses, the psychology background, pharmacy background, drama, language, commerce backgrounds, to all assist with the development of this project. And then to speak to the health the health literacy and how we address health literacy taking forward this project, we have to bear in mind that the use of health information leaflets as a tool of disseminating health information is still relevant in lower socioeconomic groups in the developing countries. So therefore, it's important to still consider this method because it's still useful and it's a great method of disseminating health information leaflet to low and semi-literate populations, and to be more inclusive of the social and demographical backgrounds of these people, to be culturally and sensitive and contextually appropriate. So the approach to developing these leaflets are more scientific ways. So it's not just pulling information from the internet and using information leaflets used in developing countries and more advanced projects and stuff, but to make it more specific to our way. And first of all, we use scientific ways such as readability testing, such as the SMOG and all those other different readability tests, and the suitability assessment of material tools, and also the patient education material tools that we use. We use comprehension and acceptability questionnaires, or everything to make it more suitable to test the comprehension and the readability of these leaflets, so to make it more user-friendly. And also, another way of making it more user-friendly, specifically in this leaflet, was to use simple language and to use interactive tools such as these that will encourage people to make use of the leaflet and putting reminders into the leaflets, so that when they do go out, it's easier for them to understand the language and the information and relate to it. Also, the participants requested that we use a scare tactic where we use images and we show people the disadvantages and the negative effects of these conditions have on the human body. They said we want to see a person and we want to see all the different diseases pointing towards the different body parts. So we all include all these things, make it more visual and more easier to understand. And because this is a participatory approach that we are taking with the end users. Also here we can see we include summaries of things, more games and more advice on how to take it forward, using pictures that are culturally sensitive, using the myths that people present to us, and then we back it up with scientific things to say, okay, is that really a myth, or is there some truth to it? So we combat those myths in the leaflets, and we use, as you see the pictures, this is a context-specific picture. This picture was very well accepted by the population because of its relevance and its context appropriateness here. So there's some examples of the leaflet that we use, and here we show the human body and all the different things that happen. So all these health information will then be combined inside a trainer's manual. And the trainer's manual will then lay out more in depth the different causes of the causes of these diseases and how to deal with them. I'll go into the content page in a few seconds, but this manual will be used by the support staff in the end for their future projects and to make the project more sustainable. Now, this manual will be implemented through a series of training workshops, and which is said the Vice Chancellor will aggregate the opening of these training workshops. We will be with the support staff to make sure that they understand the content of the trainer's manuals, and they know how to use and implement these concepts much better. A pocket guide with more simple, more summary of the trainer's manual for easy access, so they can carry around with them, and also a trainer's CD where people explain to them the content of this. So it's just making it easy. It will be for their use and also in their own home language. So the content pages you can see here with just an example, just in the draft stages, we say the topic here is tobacco use. We speak about what is tobacco use, understanding the theory behind it, and also understanding the behavior aspects to it. So understanding tobacco user behavior, why do people use tobacco, concepts such as addiction, the stages of addiction, withdrawal, all those different things, to understand the background and to understand people's beliefs and attitudes behind doing these certain things. So all these things will be included into the leaflet. And then how do we influence behavior change? What are the stages of behavior change? And how do we use motivational interviewing when we do interact with the support staff to then aid in health promotion. So all these things will then be included into the trainer's manual. The peer educators will then be trained on how to apply these concepts when they do go out and perform these health promotion things in the future. So that is important. So,
yeah, so in summary, what we would like to highlight is that the idea is to make a project sustainable. The idea is to use the available resources within the university. And in the whole process, it's all about introducing the concept of being enterprising and networking with the people around, so that pharmacy students in future, when they are employed, can look at the advantages of these kind of projects. So what is most important here is this is not an academic research where the value is just about academics. It's about a translational research where there is gain of academics, but there is also the gain of translating what has been learned into doing something that looks at empowerment of people around us and looks at health equity. And I think with that, we will close what we have to present, and we'll be happy to answer questions. Thank you.